Hello, and welcome to the Health GoLIVE webinar series. Today's episode is brought to you by our friends at Buoy. We would like to remind you that the Q&A feature will be available, so feel free to send in your questions for the panelists throughout the discussion. And with that, I will turn it over to our moderator, who joins us from Fierce Healthcare, Paige Meinmeier.
Hi, everyone. I'm Paige Meinmeier, Senior Editor at Fierce Healthcare, and I'll be moderating for us today. Thank you so much for joining us. To get things started, I'll hand it off to our panelists to introduce themselves. Adrian, if you'd like to go first.
Thank you, Paige. Hello, everyone. My name is Adrian McGadden. I'm the Chief Medical Officer at Buoy. And as an emergency physician, coming up on 20 years in the industry, either at the bedside or as a public health leader or as an executive in healthcare, two fundamental truths always are top of mind for me. And one is that staying healthy is hard and navigating healthcare is more difficult than staying healthy. And so that's one of the founding premises for Buoy, in that we want to help people navigate healthcare when it's much too difficult for the everyday person who does not have a medical degree or decades long of administering health benefits experience to be able to do so. And so in order to simplify that portion of the complexity, Buoy's reimagined healthcare navigation, created a novel approach to taking the concept of navigation a few steps further to something we call healthcare matchmaking. And so Buoy really is a healthcare matchmaker that connects people with care solutions that fit their needs perfectly.
Great. David, how about you?
Hi, everyone. Great to be here. Thank you, Paige. David Moe, Chief Medical Officer at Cerebral. We are a telehealth company, telebehavioral health, therapy, and medication management. We really focus, so I'm a psychiatrist and a data scientist by training, and really focused on how we can use data to improve mental health care for all. So two sides of this equation is access and quality. So access, we can get patients to care, over 300,000 patients already within days. And then quality of care, which is really important, measuring the outcomes for depression, anxiety, as well as serious mental illness, bipolar disorder, substance use disorders. And so we're very happy that we can serve so many people and looking forward to this discussion.
Awesome. And then Josh. I think you're on mute.
All right, first glitch of the day. Thank you, Paige. Josh Dunsby, I'm a senior consultant with Mercer, and we're benefits consultants and serve as strategic advisors to employer purchasers of healthcare, work on their workforce health and healthcare delivery strategies. So we aim to optimize the member experience, build engagement in health, and really make sure the solutions and care they are purchasing are delivering value. So really excited for today's discussion. The topic of getting people to the right care and getting them quality care has been just a hugely important topic for our clients.
Great. Thank you, the three of you, for being here to share your insights today. I guess just to set a foundation for the conversation that we're going to have, could you talk a little bit more about kind of where we are in terms of matching, employers and potential clients with, innovative platforms and other solutions that are coming down the pipeline? I don't know, maybe Josh, you want to take that first from the employer perspective, and then we can bring David and Adrian in to talk about this as well.
Yeah, happy to get us started. I think the platforms and innovation that are out there are really grabbing the attention of everyone because it's been such a difficult challenge to not just have quality healthcare, but to really get people to it. It's a lot of information and stuff for both the purchasers and members to kind of sort through. So it's that these tools and platforms that are kind of addressing the fragmentation, addressing kind of all the noise, are hugely important, and to be able to find ways to do that at the member that the member searching for care, being done in a really timely way so that it's in advance of issues is a challenge, because so much of healthcare gets kind of set in particular paths based, and kind of get embedded in patterns happen. And so addressing those early in either a particular condition or a particular patient before they've, established relationships is really critical.
maybe I'll pick up on a couple of pieces that Josh started on. One is the quality piece. I think a lot of companies have started moving into this space, and I could speak for behavioral health specifically. There are no standards of quality. And so anyone can say, okay, my app or my service can decrease depression by a certain number of points. And when you scratch a little bit, you realize that there's a wide range of true quality behind that. So having some sort of curator, some sort of figuring out how do you really separate the wheat from the chaff is, I think, is really, really critical. And the other issue that Josh brought up, I think is really important, is fragmentation. If you just think about behavioral health, right? You don't want an app for meditation and then a separate app for therapy and yet a separate app for medication management. And oh, if you have serious mental illness, you have to find another different service, right? So the idea here is that we've kind of reproduced the siloing of behavioral health care in the startup world. So how can we create a unified experience that is very patient and employee centric? I think that's really, really critical and the next step in evolution. And so certainly something that we want to be able to do at Cerebral, but more globally as well. How can we create a coherent experience that doesn't just maximize any individual company's well-being, but maximizes the value to the end user, the employee or the patient?
Yeah, and I think I'll jump in on sort of both of your points, which is really to focus in on sort of this concept of choice and more than just symbolic choice, true choice. And so I think, we've all heard over and over again that the pandemic has created lots of things that we, wish hadn't happened, but also there have been some benefits, right? Which is that it's created some momentum and acceptance and receptivity to virtual modalities for healthcare services. But that's also sort of the flip side of that coin is it's been a hyper proliferation of all these digital health services. I think I saw somewhere in the last couple of weeks that there was like 350,000 digital health services out there, 90,000 of which were founded and came about in 2020. And that's like mind boggling to me. I mean, I think probably in the 10 seconds that I just spoke, that's probably 10 more new ones that happened. And so how do you really wrap your head around that and create true choice? Yes, quality is definitely going to be paramount in making those choices. Who's actually sort of the person that can help curate those choices and be able to narrow down the field in a way that doesn't create decision fatigue? Because we all know that when we have too many choices, it creates either sort of this inertia of not wanting to make a decision, making a poor decision, or making an irrational decision because you just don't even know which way to go. And so being able to have some tools and some guidance to just kind of narrow down the field in a way that actually makes choice real versus just symbolic, I think is going to be really important.
And then kind of, that's a perfect segue to what I was going to ask next, which is, kind of the theme of today is, the matchmaker is in. How can we help match these companies with the platforms and solutions that might benefit them the most? Maybe Adrian, you want to grab this first. Kind of how are we doing that now? And what do we need to do to really get to the point where that's, positively impacting these employers?
Yeah, I think that's a really good question because I think that that's a trick question almost, Paige. It's how are we doing that now? I'm not sure we really are. And I think there's an opportunity and a gap for that to actually happen. And so I think traditionally we think about how everyone's spoken in healthcare probably the last decade or so, maybe longer, around the primary care physician being the quarterback or the coordinator of care. And so they've really become sort of this de facto decision maker around sort of how their patients select specialty referrals or other healthcare services outside of their walls. And so it would probably be unconscionable for us to add yet another layer of decision making on the primary care physicians who are already overburdened with so many responsibilities now to say, here's now 350,000 digital health solutions. Why don't you comb through this and figure out what the best one is for your patients? And so I think there's really an opportunity to be able to work with and supplement the primary care physicians' coordination activities and have a curator that can really help sort of narrow these choices down for users. And so that they're making good decisions, and those good decisions are easy decisions for them.
And then kind of to turn that question, I guess, to David, I mean, from the platform perspective, I mean, what do you think that you need that to kind of reach these companies a little more effectively and make sure they're understanding what it is that you can bring to the table?
It really goes back to this idea of a curator, because at the very beginning, when we were coming out with our clinical outcomes for depression and anxiety, a pretty unique, and also for bipolar, which no one else treats, we went around. I actually called some of our competitors and said, hey, let's come up with a standard for quality, because I think you guys are good too, and then we can be the high performing players. Not a single one called me back. And I think the reason is because everyone is coming up with their own metrics and they're all doing well by their metrics. Why would they try to change that if they can go off and sell their current product? So that curator can't be any individual company. It can't be Cerebral. It can't be any of our competitors. It has to be a different group that has an incentive to connect the companies with the right services on the other side. And we are strong advocates for that, and we would support any effort to do that. And right now, it just, frankly, we're in the very nascent phase of that. But we would love to be in a group of, let's say, high quality behavioral health providers and services that can then be presented as a group to the employers. And then we certainly each have our own pros and cons, or I should say maybe different specialties, right? And then we can go from there. Right now, we're not there yet. I think we definitely need those curators. We really need to empower those curators to come up with those metrics and have companies commit to reporting those metrics on a regular basis.
Yeah, if I can jump in, I think the state that we're at is really nascent, I would agree, which makes it exciting. I think there's so much potential. I mean, but there's really two things happening now, right? Members, patients, they get recommendations from one provider to the next. That's a fine system, but not fully optimized. And then they go on in search engines and they find information that way. And that's also really helpful, but not really a curated experience, as David was saying, and Adrian. So I think one thing I would also point to, and we'll get into this in more detail, there's quality metrics for individuals, but we're also looking at the whole system. And so quality care doesn't just mean that one individual is performing well, but it's often how they're interacting with others, they giving information back to a provider, kind of closing referral loops on things, and making sure that all of that quarterbacking is happening. So it's all those things that the patient or member doesn't even really know needs to happen, or that it becomes more seamless for them so that their experience is much easier.
We've been focusing to this point largely on connecting with employers, but as you're thinking about the potential for curation around these solutions and tools, I mean, how do you see that maybe easing the patient or the member experience, or even the provider experience as they're looking to connect to maybe the correct patient or tool?
Is that for me? Can I jump in, Paige?
Awesome, whoever wants to grab.
So I would say first, I'd love to kind of just harp on the point that Josh just brought up, which is that we know that patients are sort of seeking out information and trying to supplement things that they feel like there's a gap for. I think, there's been sort of this moniker of the patient of the future and how it's been accelerated to today. And patients are really seeking out to be more activated and more active and engaged in their own healthcare and their own healthcare decision-making. They want to sort of reclaim their own agency and autonomy about the health services that they're engaging in. And I think that's because there's this disconnect where there's been this hyper focus on the clinical aspect of the patient, but not necessarily on the rest of the patient. And so to be able to provide the support for them to regain that agency and autonomy, where they can also take into consideration all of the other non-clinical factors that go into the decisions that they want to make, their personalized goals, what it is they really want to accomplish from their interaction with the provider, I think makes it an overall better experience in general. But we can't expect them to know everything overnight. And so they really do need this supportive sort of guidance that helps them to make better decisions and make those decisions easier. And so, yes, there's the fact that you have to curate health services, but you also have to curate information that's actionable so they can understand what they need to know in order to make those decisions. And so the concept of matchmaking is not just connecting them to healthcare services, but also connecting them to the right information so that they can act on that. And I think that also makes for just a better interaction between provider and patient in general, because an actively engaged and informed patient makes for really robust discussions between the provider and the patient as well.
I completely agree with that. And maybe I'll talk about matchmaking for the patient and the provider as well here, which is something we're riffing off matchmaking here as a concept. So from the behavioral health perspective, just to give you a sense of the status quo is right now, if you say, I want a therapist, I work for this employer, what does that mean? You go and find a directory with the insurance company. There's a list of therapists and you call and you hope that one of them has an open spot. You often wait weeks, sometimes months. And it literally is next man up, next woman up, whoever you're seeing, there's no matchmaking whatsoever. That is the status quo. It's a really terrible experience. And can you imagine doing that, having to do that when you're depressed or you have social anxiety, where the very problem that you have is preventing you from seeking care? Right. So that's the status quo. It's a very broken system. One of my mentors, Tom Insel, mentioned we don't have a mental health system. It's not even broken. We never had a system. Right. What we do instead is within minutes, you can the patient can select a clinician based on his or her interest. So, for example, let's say you say, I want a therapist who's African-American, who has experience in trauma-informed care, and who is LGBTQ informed. Those are things that we can do because we have over 3,000 clinicians across the country. We can match the patient to the clinician that they prefer. This matters so much specifically for behavioral health, and we've done the data science. It really correlates with better outcomes, right? So there is and what allows it? First, it's the data, but second, it's the scale, right? And it's really important to have that scale so you can honor these requests. But that matchmaking is very, very important too. And I would encourage whoever is the curators who are coming up with metrics here for quality. One of them should be, asking the patient, when you got matched to a clinician, how good was that match, especially for behavioral health, right? Out of 5, out of 10, right? And that should be a metric, because how far is the vendor going, is the telehealth service going to make sure that the patient or the employee has a good experience? That should matter, especially in behavioral health, but I also think in medicine at large.
And you just mentioned quality again. That's come up multiple times as we've been talking so far. It sounds like there's not really much infrastructure in place to measure the quality of these solutions as we're looking to connect people to what might make the most sense to them. What do we need to do to really kind of get that quality information out there? And what are, maybe Josh, you can weigh in on this. What are employers looking for when they think about, ensuring that they're signing on with high quality solutions for their workers?
Yeah, I would start there's lots of quality information out there. And in some ways it's an overload, and in other ways there's huge gaps in the types of quality information that we would like. I think David was pointing to some of those, so we're not collecting everything that we think is important as well. From a patient, an employer, purchaser's perspective, they're a lay person. They're not a physician either. They're not quality experts. So they are looking for solutions, for partners that they feel are credible at identifying the right types of partners, organizations for to send ultimately from the benefits teams. Often they're making a recommendation. We've got this solution, we're going to try and send you to the right care, and they take that very personally, that they're delivering a really positive experience. So it's building out that ecosystem, if you will. But I think we're at a point in time that the sort of status quo of what information is available, to say like I'm doing the right thing for my employees is the bar is raising, right? They're digging into this in more detail. But it is often from the perspective of kind of member experience. Meaning, how does the member walk away from that knowing that they got quality care? the purchasers can look at sort of aggregate level reporting, and I think that's becoming more and more critical in terms of how is my population being managed. But I will say, sort of first and foremost, they are going to kind of a member satisfaction score, right? Did that was experience, however we might define it, positive to the individual? So I think that's a starting point. I think what the future is and the challenge is to shape what that positive experience is, and the education about what a positive experience should be. Because I think, that's, people don't have a great sense of what does it mean to experience quality care, right? For a person by person basis, it's very hard to say.
I might add something to the quality piece, and it's something that we have a department just measuring quality, just measuring clinical quality, and we try many different metrics. So we certainly measure NPS score, so a net promoter score, for whether the employees like the service or not, whether the members of the insurance company like the service or not. Work productivity is something that we track. So we were able to show that people miss 20% less work, 3 months after using our service, right? And this is a little bit controversial, but I really believe in this, because I actually think we should measure how we're doing with the sickest patients, with the patients in behavioral health, the serious mental illness. And I'll give you an example here. Back in the day, this is as an analogy, primary care, when we were still fee for service, right? This clinic came up, and many of you know it, Iora Health, right? ValueBased Care Center. They said, how do we prove that we're doing better care? And what they realize is you can't do it with the mildly sick patients, right? Because it's just hard to move the needle on this massive population of patients who are mildly sick. So they focus on their sickest patients. And they said that if we can get these dual eligible Medicaid, Medicare patients to do better, to leave the emergency room, not show up for COPD exacerbations or other reasons that are preventable from going to the emergency room, then they get paid. So they were able to do that, and now they're doing super well. They're part of Oak Street now, and that's value-based primary care. The same analogy, I think, can apply to every other specialty. So for behavioral health, and as a psychiatrist, that's really the only place where I can have a right to say anything. But if you look at the patients with serious mental illness, so let's say bipolar disorder, they have the highest suicide rates of any patients. They go to the emergency room on a often basis. So how are we treating those patients? And so right now, I have to say, those are the numbers that we're able to share and be very impressive to, I have to admit, payers primarily. The insurance companies are very open to having these discussions and saying, okay, let's see how you treat your SMI, seriously mental ill population. Have you reduced emergency room visits? Have you reduced suicide attempts, suicidality, things along those lines? I have to say, it's still very nascent with the employers, maybe for a number of different reasons, but I hope that we can get there, because if you can treat the patients who are sickest and need the most care well, likely you could probably treat the mild, moderate depression and anxiety well as well.
And I'd love to chime in, kind of taking it a little bit more broad than the behavioral health space, but really sort of in that whole sort of environment of all these digital health providers, which is, I think there's probably 3 core pieces where we can kind of have surrogate markers for quality care that they're providing. The first is, and maybe it's sort of was beat into my head as a medical student, 10 years ago, but I truly believe in the art and science of medicine. And so, yes, the art may vary from practitioner to practitioner, but the evidence base is not a matter of prerogative. Like it is there. And so the first step is accounting for quality by ensuring that the foundation for which they provide their services is based on evidence-based standards and practices. The second is, as Josh sort of alluded to, there's a really robust body of endorsed quality measures out there. And there's a segment of those that are for ambulatory care services, which I would argue are probably the most applicable to some of these digital health services that aren't fully fledged, unlike Cerebral, which has a full-fledged sort of offering. And so having the ability to look at some of those ambulatory care measures and being able to apply the right types of measures to those suppliers would be the second sort of piece of that. And then finally, the third piece, and this is probably my own little personal bias, which is that I feel like you really can't put yourself out there as a high quality health service unless you have equity as sort of infused through everything that you do in every aspect of your service, in keeping up with your quality measures. quality assurance, equity has to be at the foundation of that. And so being able to track and measure any disparities in the outcome and experience of the care that you're providing is also an excellent way to be able to sort of measure whether this is a high quality service provider.
And I love that idea of what are the surrogates and the proxies for, again, thinking from a member experience, they're looking for, who's endorsed these clinical guidelines and who are the bodies, of experts behind them. And I think that's very hard to sort through. So I wonder if there's ways to kind of present that better and create that part of the experience, for so that members know who kind of legitimate bodies are to be making these calls on what should be done.
And as we're thinking about quality, do you see a place potentially for, value-based models or things to kind of come into this space and kind of help manage, potentially matchmaking and access to quality data for the end user?
I mean, I could start. I would say it's, it's essential and it's really the hardest nut to crack. And in some ways it's, I don't want to say it's easy to always send someone to the highest quality care, but there's usually, there's often like a small group that's undisputed of like who that might be, but that may not, that has accessibility issues, and it has a value question of just, are we always sending people to the most costly type of care as well? So it's that balancing of, the quality, the highest quality with a reasonable cost. That's the sweet spot everybody's trying to get to. That's very much what, is top of mind for purchasers.
It's a great question, Paige. Value-based care is where we want to be as quickly as possible. When we talk to a large insurance company, and we have close to 95 million lives under coverage already, our number one thing is get us to value-based care. And we're going to set, and most of them say, well, we'll get there. So here's what you need to prove out. And we're beginning to prove that out. I think one thing that is really interesting for healthcare services is this: we actually bake in value-based care into the fee-for-service railroad tracks. So I'll give you an example. We actually come up with new billing codes that we can only bill if we can see their patients within 7 days of a hospitalization. That's super valuable to the patient, obviously, who needs care within days of a hospitalization. It's super valuable to the insurance company and the employers because that's a quality metric for them, and they're rated based on that metric, right? And it's valuable to us because we'll get paid more for that. So that's not a pure fee for value contract, but it's using the fee for service railroad tracks in order to get there, right? And I think that's part of this. We can't one day flip the switch and go binary 0 to 100 to value-based care. That's too much risk for all entities involved, right? And so the idea is that how can we move there as quickly as possible? And with some of these groups, we're beginning to say, all right, send us your sickest patients with suicidal thoughts and behaviors, and let's manage them, and then we'll take that and capitate that, right? So how do we nudge that forward with each group? And for whoever the curator is, again, of these services, I think that's part of it. What is their intent and ability for these vendors to move to value-based care, right? And I think that can be quantified in many ways, because there are certainly a lot of services that are not thinking about that way, and they're trying to drive up volume as quickly as possible. So a big believer in value-based care. That's where healthcare is headed.
Yeah, I would echo all of that. I would say that having come from an insurer before I was at Bowie, we've really seen some encouraging quality outcomes, some anecdotal satisfaction improvements, even in providers. So value-based care, particularly when the whole panel is there, it's a little different when you're split between 20 different contracts and have to juggle all those things. But when a practice and the care team is really fully committed to a value-based world, it has really shown some wonderful dividends. That said, I think we've all seen all the information around sort of the shortage of primary care providers, the shortage of providers in general. We know that value-based care means that you have to limit your patient panel to do it well. So we're really going to have to get creative about what a value-based model looks like. I love what David just introduced around sort of the railroad tracks of what fee-for-service looks like and using that as a basis. But I think with Bowie sort of being one of the first into the world of being a curator and matchmaker for care services, it's going to be really important to think through what could a value-based model look like with digital providers, and certainly making sure that we're curating providers that have a level of quality that we can rest our hats on and be assured that it's going to be quality providers, provides a really good foundation for maybe creating some really innovative value-based models and collaboration between a number of different specialties. But I think we are going to be pressed to be innovative in that type of thinking in the next few years. I don't think we're there yet, but I think it's such a provocative hypothetical that I would love to continue to think through.
Now, David, you mentioned kind of building relationship with payers as well. We've been talking about employers quite a bit to this point, but I'm curious if you think that changes the calculus at all in terms of how you want to be a matchmaker in this space, or what you're looking for in a curator if your end goal is to connect with a health plan.
Yeah, it's a great question. I think it's actually very additive and synergistic working with the payers and the employers. I will say this, the payers, employers, providers, I'll throw in pharma company, the different silos of healthcare. The payers are the most data-driven, I would say, as a group. So if you show them that collectively you can, with this subpopulation of patients, let's just make it hypothetical with patients with psychotic disorders or patients with severe depression, you could bend the curve. They'll say, all right, well, let's run a test and see how that works. And if it works, we'll scale it up. Right. So, and the reason is, so we want to talk to any entity that would do that. The payers are the most willing to engage, and we were able to get to the 95 million lives within 1 year. That's how quickly, when they see the quality, they're willing to jump very, very quickly. Employers are willing to do that as well. The reason there's a synergy here is because once we're credentialed with payers, we can now go to employers and say, hey, your ASO is a payer. And so this would be very seamless for us to fit in after the fact. So I think it is very, very valuable. I will say that the pitch to the payer and the employer is different at times. And the standards that the metrics to care about is a little bit different. And the demographics are also a little bit different, right? So I would say it's probably 80% overlap, but you can imagine that the payers might care more about seriously mentally ill. They care more about hospitalization and emergency visits, whereas employers might care more about productivity, keeping churn rate for their employees, absenteeism, presenteeism. So just different metrics, but on the whole, it's keeping the population well. So I would say we found great success targeting both and having conversations with both, and the more progressive entities within both have been very open to collaborating together behind the scenes.
I guess I would kind of hand that to Adrian as well. I mean, from Buoy's perspective, as you're looking to kind of take the role of that matchmaker, do you feel like that the approach needs to differ a little bit depending on who kind of the end user is that you're looking to work with?
Definitely, and I certainly echo many of the points that David already sort of pointed out, which is that there is definitely some overlap between employers and payers, but there is also some unique needs and considerations that employers will have, particularly employers in a specific industry where their employee makeup may not be as diverse as other industries. And so they will have a laser focus on certain things for their population of employees. That said, I do think whenever you can supplement their ability to be sort of able to service their employees in a way that helps them achieve the presenteeism, reduce absenteeism, reduces sort of just churn and turnover from their employees in general, I think you're offering an added benefit that's undeniable. Similarly with payers, I think what is shared between the two is that essentially they're trying to achieve population level health goals, right? And so if you can provide the tools for them to better manage their population's health, I think that just will pay off in dividends in the long run.
Yeah, and I would say that the choice to integrate with a carrier is really important, because not every purchaser wants to make a lot of decisions, and then their one choice is we've chosen a health insurance carrier and the rest is sort of up to them. So I think kind of foregrounding that consumer experience is important. And so most consumers, the one thing they do know are things like in network, out of network. I know I'm supposed to know that part maybe, and they're going to go to their carrier first to ask that question. And so if that's the first place people go, having that this kind of matchmaking services and knowing that that's something they should be thinking of, at that early point, that's when you're grabbing them.
And we have an audience question that I think kind of fits in with what we're talking about. And before I read it out, I'd encourage anyone who's watching to submit any questions you have for the panel. We'll be pulling them as we go. So we have a question here. It says, what role do you see for health systems looking to select digital health solutions to facilitate access, reduce costs, and improve the patient experience? If employers are making these choices, doesn't that kind of take providers out of the mediation role and can potentially break continuity for patients who may have chronic illness?
Maybe I could start with that. It's a great question. And so I don't think it's either or. I think the winners in these digital health solutions will coordinate with all these different entities, right? So for example, we are actually working with some of the largest health systems right now to directly take their discharges. So they will just discharge to us through our telehealth service. And we guarantee them again that we see them within days. And then that we soft guarantee that they won't get rehospitalized within 30 days, right? Which is valuable to now the health systems as well, since the payers it's all connected. The payers don't want them to be rehospitalized. They don't get paid for that, right? So now the health systems don't want rehospitalizations, right? Which is good. I also think, I'll just say that this is where entities like Buoy are just super critical, because you need a digital front door, and that digital front door can come through many types of doors, right? It doesn't have to be one door. It can be multiple doors. So you're coming out of the hospital, you go to your payer's website, you're going through your employer's EAP program and looking at what's available there. You're Googling, right? So having all of that be a go-to the optimal service that you're entitled to as an employee is super, super critical, right? So I would say the winners in the digital health space here are not ones that are saying, okay, I'm just committed to payers, or I'm just committed to employers or hospital systems. They really need to be able to negotiate the straits to create relationships with all of them and be additive and not choose one against the other, if that makes sense.
That's right. I think the supplementary nature of this whole space is what's really sort of, I think, the carrot. And so from our standpoint at Buoy, we do feel like it is supplemental to the provider space and not sort of antagonistic or competitive to it. And so as David sort of just pointed out, that use case where you work with the health systems in addition to potentially the employers and the carriers, and work in a way that is beneficial to all. And remember that when the employers are providing these services, this is almost like a financial benefit for the employees as well. So it's not meant to be a disintermediating action. It's actually meant to help facilitate the use and the role of some of these supplemental sort of health benefits so that people can stay healthier. And so it really is seen as a synergistic tool for the health systems and other provider spaces.
And Adrian, earlier you touched on kind of COVID and the impact that has had on, the explosion in use of telehealth, virtual health, and these different platforms. Are you kind of feeling momentum around that then, that in tandem, kind of the demand for someone to assist in breaking through the noise is really growing as interest grows?
Yeah, I think there's been so many signals in different ways. I think one, we saw sort of this massive influx of utilization of telehealth early on in the pandemic, but even when it sort of leveled out, it leveled out at a much higher rate than where we saw pre-pandemic levels. Similarly, I think there's been a lot of healthcare consumer surveys where it shows that people are really starting to take to virtual visits and anticipate continuing to use that in the future. Regardless of whether the pandemic continues to be around or if it becomes endemic or goes away completely. The other thing I always tease about, and I feel strongly about this, is virtual care, telehealth is the oldest new innovation that there is around. It's been around for decades, yet we see it as this new innovation. And so I am thankful that we've seen this progress and this mobilization of acceptance around virtual modalities, because I think it's been around for a long time. We've had a while to be able to work out the kinks. I think there's still opportunities to do that more, but we've got some really high quality virtual care providers. And you can kind of see the passion in David around quality, and there's others that are definitely sort of prioritizing quality. And so I think that just goes to show you that telehealth is not a new kid on the block. It's been around for a while.
Yeah, if I can add to that, completely agree with Adrian on telehealth is here to stay. And, there's a really ugly study done in the New England Journal that shows that when there's strong evidence in medicine, how many years does it take before we widely adopt it? It's 17 years. And that makes all my friends in tech shrivel a little bit and say, how is that possible? That is true in medicine. So what I'll say is right now, it's really interesting. There's a knee-jerk response to say, how does telehealth compare with brick and mortar care? And it becomes this thing, telehealth versus brick and mortar. And I think that's the knee-jerk reaction. And I hope that we very quickly go to, no, the difference is between high quality care and low quality care. And so high quality telehealth and high quality brick and mortar, and then low quality for both of those. Because I can't tell you, both in our field in behavioral health, as well as other fields, you get this, there's a telehealth company and there's a teardown of that company by some article. And the people who are pontificating about it are coming from a top university, or Harvard or Stanford or Yale. And no one asked them, what is your quality outcomes? What is your wait list? No one asked them. We just presume that they are the best at those things. And I think let's create those metrics and let's hold everyone to it. It can't just be, okay, the telehealth providers have to show their quality, but the incumbents don't have to. Because why? Because we just trust them, right? So I would just say that those curators should definitely level set across the board, and that would also help employers figure out, well, how much should we lean into telehealth for which specialties, for which subspecialties? That would give you a much more refined way of doing this more surgically, rather than thinking, okay, are we in on telehealth or are we out of telehealth? Right? I think we just have to be much more minute and surgical in our strategies there.
Yeah, and I think over time, I mean, the distinction between virtual health care and, I don't know, regular normal healthcare, starts to fall apart. It's members, patients, they want access to both. They want the convenience of being able to use that old-fashioned technology of calling someone up on the phone, and you can actually get a lot done that way. And if it's digitally enhanced with video and lots of other information, that's fantastic. But the last thing we want to do is just add fragmentation by creating one class of providers that are distinct from another. I don't think anyone's looking for that.
Yeah, I certainly think hybrid's going to be the new catchphrase for 2022, both from the workplace and as far as healthcare as well. So,
and I guess while we kind of are on the topic, I mean, are you feeling the impacts of COVID in any other ways as we're thinking about, the proliferation of these virtual tools and kind of how we can make sure people are really connecting to the things that are right for them? Give me a second to contemplate. Great. Cool. So I will actually move on to, we have a question here from the audience as well. So we've been talking a lot about, matchmaking and kind of different scenarios on who could be doing that, but ultimately, who do you think should play the role of triaging and matchmaking? And, should payers play that role? Should providers own that relationship? And maybe does it change depending on kind of the tool you're looking at?
I'd love to jump in first. Certainly, I think both payers and employers or providers have a relevant role in there. I don't think they should be playing the matchmaker role. And I say that only because traditionally, when we've thought about all the stakeholders involved in a healthcare interaction between a patient and a provider, I think though well-meaning, we certainly unintentionally seem to deprioritize or undervalue the needs of the patient in all of this. And so when you have one or the other sort of playing that role of matchmaker, I think they prioritize their own needs, potentially to the detriment of the patient. So I think having a neutral third party that can certainly take into account the needs of all three sides of that interaction would probably be the most beneficial matchmaker, in my opinion. That way that you know that all the needs are represented in a way that will provide the best match possible for that healthcare interaction.
Yeah, I agree with that. I'll say the way I think about it is the payer and the provider, they both have to be part of this, right? So to me, it's a data problem. So the payer knows certain pieces of information about this patient. They know they've been in the hospital many times. They know that they have comorbid conditions. They know all of these different things, and they say, okay, this is someone we want to focus on. Sometimes the provider doesn't have all of that information, right? It's not right in front of them. They don't have the claims data right in front of them, but they have the relationship with the patient, right? So it has to be a very carefully choreographed dance between the payer and the provider to get them to the best care. And there are many good models for this. For example, payers have a fleet of care coordinators, and these case managers will connect a patient when they call in to a provider, and they can really make that process very smooth and call the provider on the phone, hold, and then immediately it's a seamless transition, right? So I think that has to be a carefully choreographed dance. I will say, to Adrian's point, what percentage of patients access healthcare that way now, where they call their insurance, they look at the back of their card and call? Probably a minority. I don't know the numbers, Adrian, I'm sure you do, but the vast majority Google it. The vast majority of people look for it in different ways. And so now that's now incumbent on the payers and the providers, I would say, and the employers, to make sure that they've got those digital front doors covered as well. So those patients don't end up out of network accidentally, right? And that percentage of people who seek care that way is only increasing. As no one, very few people, I think, under the age of 25 are looking at the back of their insurance card and saying, okay, who should I call and what directory should I get, right? So I think all these entities need to work together to get those to work with those digital front doors. But it's also important on the back end that the payers and providers connect and align.
And I love this question because I think there's so much to it. I think there at some level foundationally, like there's guardrails on everything, and that the physician needs to be the one to direct care, and so there's that's pretty embedded in the healthcare industry. But I think what to me so interesting in the core part of the question is like who's really accountable for that. And I think in our discussion already we could see there's lots of different individuals, entities that are potentially accountable for that. And I think it's there's different arrangements, right? Fundamentally, these are the ideas of the accountable care organizations and who's responsible. I mean, I think personally, a lot does go back to the primary care physician, that there needs to be, the member needs to know that there's sort of one person who's my quarterback, or one care team that's my quarterback, and so that they always have a place to go back to, and that only works then if that provider is accountable. And I know, like Adrian mentioned before, like the idea of patient panels and creating, so there's so many levels to this question of like creating the accountability.
And Josh, you mentioned the primary care physician. We have a follow-up from the audience as well. When you're thinking about, again, who should own this, what do you see the role of the PCP as being in this equation?
I think super critical to Josh's point. I think here's the thing. PCPs are very busy. I believe Adrian mentioned it earlier, 7 minutes a patient. You can't expect them to be able to discern which services should I send to and whatnot. It has to be, we have to make their lives as easy as possible. So one other metric for, I think, the curators of care when they're looking at different services is how much does the vendor, the telehealth service or the healthcare service, how much do they integrate care, and and measure it, right? And you can do it by just randomly calling some patient and say, did they give the information back to your PCP did they coordinate with another one of your providers, right? And for patients who really, really need that, because I think what I find is a lot of people say, yeah, we coordinate care, but they don't really, right? And coordinating care also isn't faxing a ream of paper to the PCP and then say, okay, we did it. We sent it to the PCP, we're done here, right? It's figuring out what pieces of information that's really actionable for the PCP or for an oncologist who referred the patient or for whoever it may be. It might be just the diagnosis and just the medications you put them on so they can know if there are any contraindications for other meds, right? So just one example, but the idea here is that we should quantify that coordination of care that I feel like everyone is saying they're doing, but very few people are actually doing effectively that leads to improved clinical outcomes. So hopefully, that's a hard thing to measure, but Adrian, you guys are very smart over there. So hopefully you guys can figure that out, how to quantify that.
Yeah, and we've definitely thought about that, David. So good to hear that validation. The other thing I want to say is I've said this before, and I will give a caveat that I am terrible at sports analogies, but I'm going to give it a go here. We always talk about the PCP as the quarterback of care. In my mind, they are so important that they deserve in our mindset a promotion, right? Like the quarterback is on the field, they're kind of executing on the plays and the playbook that have been given to them. I think that the PCPs are actually more like the coach or the offensive coordinator who's really sort of conducting and teaching the quarterback how to make the right play in the right situation, and that the patient needs to be elevated to some level too to be a quarterback because they're living their lives on a day-to-day basis. They don't have their PCP on speed dial every day. I think if we did that to PCPs, they'd be crazy to have 1,500 calls or more every day trying to figure out what they need to do on their day-to-day basis and health decisions. But being able to sort of coach, mentor, and provide expert adjustments to the decisions that patients are making on a day-to-day basis as they encounter different contexts and different scenarios and barriers that they have to then make a decision on in the moment, I think makes them more of a quarterback than we give them credit for. But we also know that there's an elevated expertise that the PCPs have, and their importance cannot be understated. And so I really do feel like there's got to be a promotion in our minds, not referring to the PCPs as quarterbacks, but more so as offensive coordinators or head coaches, and the patient is a quarterback, because they both have very important roles in this decision.
We have just over 5 minutes left, so I would encourage the audience, if they have any last minute questions they'd like our panelists to answer, to get those in. But I guess, just to kind of put a bow on what we've been talking about, we've laid out a lot of different angles to this matchmaking equation over the past hour and a lot of different challenges. What does kind of then the ideal version of this look like? And what do we still need to do to get there?
So I'll jump in just simply because I gave that long-winded analogy and just finish it off right with a little bow. I think what the ideal version looks like is having a matchmaker that allows a patient with now an elevated role in their own health and healthcare to be able to make good decisions, timely decisions, informed decisions. And so having a matchmaker that provides guidance through actionable information, but also provides guidance with curated choices of high quality providers and suppliers that they can be able to access in the moment when they need it. And that also close that loop back to the primary care provider feels like a really tangible near future, near term opportunity that can be executed. And those are sort of the things that we're looking at as matchmakers in care at Bowie. So that would be my vision.
And Adrian, I first just want to say that was a fantastic sports analogy. I absolutely loved it. You're a clear football fan. So, I would say the matchmaker from the vendor perspective, from the telehealth perspective in general, is that, give us the metrics for quality, right? Give us some universal and get the experts around the table to do that, because the best providers, we want those metrics and we want to be measured against that so we can differentiate, right? And the other ones who are not saying that, well, that's a little bit scary, right? So that's first. And then second of all, that would also help spur the innovative community more, right? Because now if you're thinking about a startup, you know where your North Star is, instead of thinking that, okay, I just have to hire a lot of people and then come up with some data and create our own metrics for success, right? So give us those metrics for success, whether it's behavioral health or MSK or primary care or whatever it may be. If you set those standards, and they don't have to be set in stone, you can update them year on year, right? That's perfectly fine. But it gives us a sense of where we stand relative to others, and it gives us an ability to improve the things that maybe we're not great at. So I think that would be really, really helpful for us, so that there's less smoke in the mirrors, less snake oil out there.
Yeah, and I would just add, I think, from the members' perspective, like they want, what's positive for them is that they're reassured, and that some of the uncertainty of making a choice has been, reduced for them. Because I think that's often the biggest fear, is not necessarily did I make the very best possible choice, but also like, am I making a bad choice, right? And so being able to guide people to that selection is really important, that they have some the trust in the overall solution is critical, and how that's presented to the member is ultimately what's really positive for them.
Great. Well, I want to thank the three of you again for your time and your insights today, and I want to thank our audience for tuning in. Bye.
Thank you to Paige and all of our panelists. Please visit our website at hlch.com to catch up on all Health Go Live webinars. And join us at the inaugural ViVE event, the industry's new health information technology event, coming to Miami Beach, March 6th through 9th, 2022. Hello, and welcome to the Health Go Live webinar series.